Hello, everyone. So we have now returned again with a new learning case, which was discussed during our intradepartmental discussions. This is a case of a 19-year-old boy where the parents gave us the alleged history as given by their son that he stood over the roof of a static locomotive and then something touched his head, as a result of which he was thrown on the ground. He lay there unconscious for a few seconds to a minute. Parents said that their son told about a minute and then, after gaining consciousness, walked back home. Now, after about 2 to 3 days, he started having weakness in all the limbs, starting in the lower limb and then involving the upper limbs, which rapidly increased to affect almost all the muscles of his body. And by the fifth day, he was put on ventilator by the treating doctors. So there were no external shock-related burns or injury marks on his body. However, there were bruises due to the falling on the ground. The patient's films, MRI films, were referred to our department for second opinion to know the prognosis. And the modalities available with us were MRI films, and no previous films were available for comparison. So apart from the T1 and T2 showing hypo and hyperintensities of the white matter, the flare showed typical finger-like hyperintensities involving the centrum semiovale, as well as seen in the large film involving the white matter of both frontal lobes. There were hyperintensities seen in both lateral ventricles, the occipital horns, which suggestive of bleed. The finger-like hyperintensities were very classical. They were extending from the subcortical white matter till the periventricular area. So these were the other sections of the MRI on flare, which showed that there were hyperintensities seen also in the bilateral temporal lobes, and the lobes were quite edematous with effacement of the sulci. There were hyperintensities in both frontal lobes, occipital lobes, the bleed as already depicted, and classical hyperintensities along the white matter bundles in the centrum semiovale, as seen here. The diffusion and the ADC films of the patient showed that the lesions were showing restricted diffusion, which was showing reversal on ADC. In all those areas, wherever there were hyperintensities on the flare, also the bleed was noticed in the occipital horn. So the diagnosis as given by outside was similar that was given by us, that the high voltage electric shock on the head led to predominantly diffuse white matter injury secondary to the infarcts and demyelination, and few areas of hemorrhage were there leading to the intraventricular bleed. The point I would like to add here that Indian railway traction system usually uses 1500 volt direct current, which is around Mumbai, and 25,000 volt alternating current, which is used in rest of the country. So even if a live wire touched the patient's head, the severity of the injury was quite high in this particular case. Coming to the literature review, the mechanisms by which electricity causes injury are not completely defined, but include several pathways, and the most important of it is thermal, where the large quantities of heat is produced by current passing through the victim, either the whole body tissues working as a parallel circuit, resulting in external and internal burns. Another important mechanism is electroporation, in which the membrane proteins permanently change conformation and can no longer maintain transmembrane ion gradients, therefore resulting in cell death. Direct physical forces involved in the injury, like person thrown from the site, and indirect physical forces like person losing consciousness and falling from the ladder can also injure the victim and could be one of the mechanisms of injury to the head. Now, in 1995, Sherrington categorized electrical injuries which he observed in multiple patients into 4 groups, which were useful in understanding the electrical injuries, as well as in categorizing them, as well as in guiding appropriate imaging. So the first category he categorized them were immediate and transient injuries, and these injuries were apparent immediately after the event. Examples included loss of consciousness, amnesia, confusion, paresthesias, and weakness. They are the most common, but often resolve within minutes to hours, and usually the CT scan and MRI were negative. So on reviewing the literature, we found one case report in which there was brain injury resulting from the high voltage electric shock. to the scalp. There were burn marks on the scalp, and there was a finger-like hyperintensity in the white matter as seen in this case. However, just like this category, after 2 months of re-imaging or after repeating the imaging, the edema as well as the hyperintensity resolved. The second category in which Sherrington divided the patients of electrical injuries to head were immediate and prolonged symptoms. They were less common but debilitating injuries. Examples included hemorrhage, chromolysis of pyramidal and other neurons, as we are seeing in our patients, glial proliferation, and infarction. The factors postulated to contribute to this category included the length and severity of the insult. In our case, the severity was very much high. And in severe injuries, the entire brain or parts of the cord could be swollen, softened, or even defluent. In our case, also, we were finding that there were multiple white matter tracts suddenly showing changes of infarction and demyelination. There are few case reports in the literature review in which there are prolonged symptoms as well as there are prolonged changes in the brain. In this particular case of a cerebral corticospinal tract injury resulting from high voltage electric shock, there were changes or there were white matter hyperintensities in the corticospinal tract on the left side even after 5 months of the injury. The third category is delayed and progressive. It is difficult to define clinically because differentiating between it and the immediate and prolonged or permanent category may not be possible. Numerous conditions have been reported in this category, including basal ganglia disorders, myelopathy, and motor system disease. I would also like to add that all neuropsychological and psychomotor symptoms appearing later in the life of the patient, sometimes even more than few months later, are also included in this particular category of delayed and progressive injuries. There is a fourth category, that is event-associated injuries, which is most obvious. Example include trauma or hypoxic injuries due to any other organ failure. There is a beautiful article in the internet, which I have just projected here. I would request everybody to go through this article. And as per this article, an alternate anatomical classification post-electric injury can also be tabulated as central syndromes in which there could be hemorrhage, infarction, encephalopathy, convulsion, and movement disorders can be clubbed together, which are secondary to the injury happening in the cerebral hemispheres. Then the second category is cerebellar syndromes. Third, cranial nerve-related injuries, which can be seen in many cases. There are many case reports. Autonomic injuries, in which there comes the complex regional pain syndromes or reflex sympathetic dystrophy, secondary to electric injury. Fifth category could be spinal cord disorders, including paralysis. And sixth one, peripheral nerve disorders, including motor and sensory abnormalities. So this alternate anatomical classification can also be kept in mind by a radiologist when he is looking at a case of electrical or a case of MRI post-electrical injury. Thank you very much.